lecture. I'm Jian Lee and I'm the host for today's lecture. We are excited to continue the online series following its success over the past year, which you can check out on our YouTube channel, CPM Oxford. For first-time viewers, this is an online lecture series that hosts a wide variety of keynote speakers from around the world who are at the forefront of the COVID-19 research. Our objective for the series is to invite brilliant minds to give talks that are research-focused and on a wide range of subjects to foster learning, inspiration, innovation, and provoke conversations that will dictate the future of healthcare. Before we begin today's lecture, I'd like to briefly introduce the organization hosting the series and our guest speaker, Dr. Nayia Petousi. This lecture series is hosted and organized by the Oxford Personalized Medicine Society, a student and faculty-led organization that works to weigh the benefits and detriments of personalized healthcare in modern-day medicine. A partnership program between the Wellcome Center for Human Genetics and St. Anne's College at the University of Oxford. Throughout the year, we collaborate to hold research talks encompassing a diverse array of subject areas, annual Oxford Personalized Medicine Symposium, and workshops for all affiliates of the university. If you're a current member of the university and would like to get involved, please register using the display QR code. I'd like to highlight that membership is free, unlike many other societies at the university. If you have any questions about the society, please feel free to contact us at oxmed@ox.ac.uk. Today's lecture features Dr. Nayia Petousi, who will be delivering a talk entitled COVID-19 from a Respiratory Physician's Perspective, Acute and Long-Term Effects, discussing on the various respiratory complications of COVID-19. Dr. Nayia Petousi is the Consultant Respiratory Physician and Senior Clinical Research Fellow in the Respiratory Medicine Unit, Experimental Medicine Division, Nuffield Department of Medicine at the University of Oxford. She completed her DPhil Physiology at the University of Oxford, where she taught as a clinical lecturer in respiratory medicine. She was also a former clinical research fellow at the Wellcome Trust. Dr. Petousi has recently been involved in the publication of a paper entitled Successful Awake Proning is Associated with Improved Clinical Outcomes in Patients with COVID-19, Single-Center High-Dependency Experience. Please use the Zoom chat to submit questions for the short Q&A session at the conclusion of today's talk, and we'll get through as many of them as we can. Thank you. And now, without further ado, we'd like to welcome Dr. Petousi to deliver her lecture. Please stand by as we transition to a presentation. Thank you very much.
Thank you, Jian Lee. I'm trying to share my screen, but it's... So I think it says host disabled and the attendee screen sharing. So I can't share my screen.
I'll enable it now.
Okay. Still the same.
Is it Chris? Could you
Sorry for the
make a
technical
co-host, because I don't think it's letting me do it from my device. Thank you.
Yeah, it doesn't let me do it. It says host disabled, attendee screen sharing.
Will it let you do it now? It should let you do it now.
Yes, great. Just a minute. Okay. Is that all right? Yeah?
Yep.
Okay. Thank you for the introduction. As Jian said, I'm a consultant respiratory physician at the University of Oxford University Hospitals, and also a clinical research fellow. And what I wanted to do today is just is really to give an overview of our experience in respiratory medicine during the first surge of the COVID pandemic, and also give you some perspective from a physiologist's point of view. My research interest is in respiratory physiology and hypoxia biology. So I want to talk a bit about the acute features of COVID and how we dealt with that as respiratory medics, but also I want to talk about the long-term effects, because I'm also involved in a post-COVID respiratory clinic where we're seeing patients with complications of COVID. And again, I'll talk about the clinical aspects and also some potential research aspects of what we do. So so the first thing that I wanted to say, sorry, I have a slight problem. I keep seeing everybody at the bottom. I don't know how to remove. Yeah, that's it. Thank you. So the first thing I wanted to just remind everybody was what it was like for us, for all of the healthcare professionals that really had to deal with the first surge of the COVID pandemic here in Oxford, because we had to prepare very, very quickly for this, and it was 3 months of very intense work. And I just wanted to pay tribute to everybody, all of the healthcare professionals and key workers that dedicated their time and to deliver. Particularly the respiratory team, because we had a great team of nurses and junior doctors and physiotherapists working together to try and deliver something really, really good for the patients. So what we did was we set up a respiratory high-dependency unit. We moved our ward to a different area, a large area with single beds, so that we could deliver safely respiratory support for these patients. And while we were going through all that, I found this this table here from the Intensive Care Society, from a clinical psychologist, Julie Highfield, particularly helpful in dealing with the various emotions going through that. And for me personally, I thought the most difficult bit was the beginning, the pre-phase and the initial phase, when we were sort of preparing the anticipatory anxiety, the readiness burnout, when we started getting going, trying various different things, trying to find your feet when you're not quite, you're dealing with a disease that you've never seen before. But actually, once we got going and we were going through the core phase, it was almost a little bit like an autopilot. Everybody worked as a team, lots of adrenaline going, and I actually found that period quite rewarding. As a doctor. Personally, I haven't experienced much of the sort of end phase, long-term phase of coming out of the surge the second time, but I think this was quite a useful table to just identify where you're at. And of course, that's what we looked like during the pandemic, and that's what we're going to be like now, because we're seeing, as you know, the cases going up again. So in terms of the acute COVID-19 infection phenotypes, as you know, some patients present with very mild disease, cough, myalgia, fever, anosmia. They don't really require hospital treatment. No oxygen treatment required. But the cases that we saw in our respiratory high dependency unit were those that had severe COVID-19 pneumonia, patients with severe hypoxia, typically type 1 respiratory failure, meaning they had very low oxygen levels but normal carbon dioxide, so they were not in ventilatory failure. And typically they had very severe pneumonic changes there on their radiology. Quite a lot of them had pulmonary thromboembolisms. And I think the experience from our center was that about 30% of patients that had a CTPA for COVID reasons actually had a positive scan for PE. And there were other patients that predominantly presented with thromboembolic disease, even though they didn't have much by way of respiratory changes. PEs or DVTs or even arterial thrombosis stroke, because as you know, COVID-19 sort of induces a prothrombotic inflammatory state. And what was quite interesting in the patient cohorts that we saw, and that is seen across the world, is that the patients that we looked after with severe COVID-19 had predominantly vascular risk factors, so increasing age, hypertension, diabetes, ischemic heart disease, and obesity. And really the patients that we are normally looking after are patients with chronic airways disease, asthma, COPD, cystic fibrosis. They were really nowhere to be seen on our ward, which was quite interesting. And some of it may be the effects of shielding, of course, but I think some of it is to do with the disease and predisposition and what type of disease COVID-19 is. And there's quite a lot of evidence that perhaps we're dealing more with a vasculopathy rather than necessarily a typical respiratory viral illness. And I'll come back to that point later. But the other thing that was quite interesting, which again I'll touch on later, was this phenomenon of what we term happy or silent hypoxia. So there are patients that have presented with a significant degree of hypoxia, very low saturation of oxygen at 80%, but nevertheless the perception of breathlessness was not there. So people didn't feel extremely breathless, unlike other illnesses such as pulmonary edema or more conventional pneumonia, when patients have similar levels of hypoxia. So that was also an interesting observation, which I'll talk about. So what we did, as I said, we set up a respiratory high dependency unit. We were prepared for 2 wards, 50 beds in total. In the end, we only needed to accommodate 1 COVID ward for severe COVID-19 pneumonia, single beds, single rooms, and really we tried to protocolize everything. We had a very skilled group of nurses and a group of physiotherapists that came on the ward round daily, and their input was extremely valuable. And a sort of algorithm that we had in terms of admitting patients to the HDU, the referrals were predominantly from general medicine, and it was really patients that had increasing oxygen requirements in a short period of time, or really absolute oxygen requirements above 40% FiO2. So those patients were transferred to the high dependency unit. And the main, apart from all the other treatments like thromboprophylaxis and antibiotics, the main treatment we provided was respiratory support, and that was a non-invasive respiratory support in the form of CPAP, continuous positive airway pressure, and proning. And by proning, I mean patients were encouraged to lie on their tummy, on their abdomen, for ideally 4 hours a day if they could manage, 2-hour intervals at a time. And that is either in combination with CPAP or without CPAP during breaks with oxygen. And the treatment we gave was continuous positive airways pressure with oxygen. We had to adapt the circuit to make it safer for the staff. And if patients were not tolerating CPAP very well, we might consider slight sort of mild sedation. And sometimes if they were more intolerant, to be able to continue to oxygenate them, we would give them high flow nasal oxygen. So, and for patients that, we had a mixture of patients, for patients that were candidates for ITU, at every point in this algorithm, there was good communication with the ITU team, so that if someone really needed to move on to higher intensive care the form of mechanical ventilation, then that was done, and that was quite important. So by continuous positive airway pressure, for people that don't know, this is a treatment that we normally use for obstructive sleep apnea. So it's usually delivered through a machine that pumps air at a pressure, and you have an interface with a mask over your mouth and your nose, and you can also feed in, of course, supplemental oxygen through that. And the aim really in this sort of medical case is to try and recruit more alveoli and therefore improve gas exchange and ventilation through the lung. And so I just want to talk a little bit about the paper that we've published from our experience in the high dependency unit on how we use CPAP and proning. And essentially this work talks about the first COVID surge, and I think the data are up to about mid-May, or early May, mid-May. So they're predominantly, yes? Can I carry on?
Please remember to mute your audio.
Oh, okay. So, so mid-May, and this shows the number of patients admitted to the hospital up until that point. Many of them managed in medical wards, some of them in intensive care. Up until that point, we took 71 COVID-19 patients admitted to the high dependency unit. We had more patients on the unit that were stepped down from ITU, but these are the patients that directly came to us from medicine, and about 54 of them required respiratory support, and 48 of those were the ones that we tried very hard to give them CPAP and keep them well with CPAP plus or minus high flow nasal oxygen. And just in terms of the breakdown of the patients that we saw, as you see, most of them were more elderly, median age of 69. And as I mentioned at the beginning, really the breakdown of the risk factors is really patients that had vascular risk factors and less of them that had chronic lung disease. And one interesting, and one thing to remember, of course, in this cohort of patients, a significant number of these patients, this was their ceiling of care, the high dependency unit. A small number of patients were candidates for further treatment with mechanical ventilation. But what we really tried to do is give the best possible chance to the patients that were not going to go to intensive care with non-invasive respiratory support. And for patients that were candidates for intensive care, we tried to reduce the risk of needing intubation or delay the risk of intubation, give them more time to recover. And indeed, data, as you might know, initially when the approach from Italy and from China was to intubate early, the mortality was very high in that group of patients, and there's some reports of almost up to 80% mortality rate in the mechanically ventilated patients, and this has now come down quite significantly, less than 50%, which and some of it is being able to sort of hold the patients and keep them well with non-invasive respiratory support. And what we found, it was really patients that were managed on CPAP did better than patients that could not tolerate CPAP or and had to be given high flow nasal oxygen instead. And actually, indeed, high flow nasal oxygen, we haven't found in our experience and in other people's experience that it's really that helpful in terms of keeping patients without the need of intubation, whereas CPAP is. But the main also finding was that we were encouraging awake proning in these patients, and we found that independently in a multivariate factor analysis was associated with with a better outcome. And and while in other sort of illnesses such as acute respiratory distress syndrome, proning is done in ITU in intubated and ventilated patients, and it's believed to be working through perhaps recruitment of more lung units. Actually, we think that perhaps in COVID-19, a good beneficial effect of proning is actually redistributing blood flow in the lung and improving ventilation perfusion mismatch. And indeed, it was quite obvious. You could see that patients after proning, they really had much improvement in their oxygenation. So I think this combination of treatment, CPAP and proning, we found that it was very successful. So this was our experience from the first search, and I think we know a lot more on what to do now. But what I wanted to talk about making these observations is really sort of the perspective of a respiratory physiologist, or someone that has spent a lot of time thinking about hypoxia, because the hallmark really in this illness from the respiratory point of view is severe hypoxia. And through our observations, but also there's quite a few perspectives in the literature that I will, and some reports in the literature that I will go through here. Essentially, in COVID-19, the problem is one of oxygenation rather than ventilation. So if you take just an example of a patient where you have a patient presenting with quite severe type 1 respiratory failure, so low oxygen level as you see here, and that is on oxygen just before requiring intubation. But the carbon dioxide, as you see, is normal, so really or even low. So there's not really a problem of being able to ventilate the lung. It's mainly hypoxia. And the other thing that was quite remarkable is that you see these patients had normal blood pressure, normal heart rate. They were not particularly tachypneic, despite this very severe degree of hypoxia. And that's quite unusual. This is not what we normally see in patients that are sick with sepsis and pneumonia or pulmonary edema. This was quite different in a lot of patients. And indeed, the experience from our intensive care colleagues is that COVID-19 does not cause a typical acute respiratory distress syndrome picture. As you might know, in acute respiratory distress syndrome, there's some sort of similar radiological findings with a lot of infiltrates and interstitial changes and severe hypoxia. But unlike ARDS, what we see in COVID-19 was that these lungs were easy to ventilate. They had preserved lung mechanics, preserved compliance. And really what you saw was hypoxia out of proportion to the ability to ventilate the lungs, indicating a large degree of shunting. Shunting means blood that flows through areas that are not well ventilated or where the gas exchange is not good. So you end up having a lot of deoxygenated blood with low oxygen going into the main circulation. And one, a hypothesis that may be valid as to why this is happening is that perhaps there's failure of the body's homeostatic oxygen sensing or response to hypoxia. So as I just said, lots of shunting and severe ventilation perfusion mismatch in this illness. And we've made these observations, but of course a lot of people around the world have made similar observations. And one possibility is that what we might be dealing with, or one potential contributing factor is perhaps that hypoxic pulmonary vasoconstriction may not work as well in this illness. And just to remind you, or for people that may not know, so hypoxic pulmonary vasoconstriction, what that is that in the lung, when you have a lung unit that is heavily diseased, so it's not ventilated anymore, so no air can easily go there, so no oxygen essentially can go there to participate in gas exchange. As a compensatory mechanisms, blood vessels that flow around there to try and pick up oxygen, they vasoconstrict, essentially in a means to try and divert blood to the good areas of the lung, to the well ventilated areas of the lung, so that they pick up oxygen where oxygen is high. And this helps improve ventilation perfusion mismatch. If hypoxic pulmonary vasoconstriction doesn't work as well, so you've got a very diseased alveolus here, and the blood vessels cannot constrict, then essentially you have a lot of poorly oxygenated blood mixing with oxygenated blood, and this is what we call shunting. So given that we see quite a lot of shunting in COVID-19, that is a potential problem that may be going wrong in COVID-19 that might explain some of this high degree of shunt and ventilation perfusion mismatch. And there's a nice perspective in circulation by Stephen Archer that sort of alludes to that and compares three very hypoxic illnesses: ARDS, which I've talked about earlier, high altitude pulmonary edema, and COVID-19. And what characterizes all of them is severe hypoxia, so low arterial oxygen in relation to the inspired oxygen. As we talked about, very mild dyspnea in the COVID-19, but quite severe dyspnea in the other two conditions. Severe VQ mismatch in COVID-19, not as much in the other two conditions. Not much by way of pulmonary hypertension, which it would be caused if hypoxic pulmonary vasoconstriction worked well in COVID-19, but a high degree of pulmonary hypertension in high altitude pulmonary edema, where there's global hypoxia, moderate in ARDS. And as we talked about, affected lung mechanics, not able to ventilate lungs very well in ARDS, but not so in COVID. So I think these sort of comparisons may make plausible that there may be impaired hypoxic pulmonary vasoconstriction in COVID-19. And this kind of lack of sensation of breathlessness or the way the body responds may indicate further abnormalities of homeostatic oxygen sensing. For example, it could be that the way the carotid body works in terms of sending signals to the brain in response to hypoxia and changing ventilation and breathing may be affected. It could be other neurological effects that affect the sensation of breathlessness. So these are all interesting hypotheses. They're quite difficult to test, of course, in practice. But I just want to give, I just want to just make one short reference here to this study that is being planned here at Oxford, which is led by Professor Peter Robinson. We're working with him from the clinical side to try and trialing a drug called almitrine, which is a very old drug that was used in the past to try and stimulate respiratory function in COPD, and there's some evidence that this drug may affect processes like hypoxic pulmonary vasoconstriction and improve VQ mismatch, to see if by trialing it in patients that need oxygen and respiratory support, whether we can improve their hypoxia and perhaps prevent them requiring sort of ITU and ventilation. And this has not started yet, but this planning is in progress. So some evidence that perhaps this hypothesis is valid. So these are some nice images from the Lancet Infectious Diseases, where you see patients with severe COVID pneumonia, no evidence of pulmonary embolisms, but what you see here are very dilated pulmonary blood vessels in near areas of pneumonic changes. And on the right, what they're saying is that they can see areas of hyperfusion, a halo of hyperfusion, which again may indicate that there's some pulmonary vascular dysfunction. Could be related to HPV, could be related to other reasons, but this has been demonstrated in imaging. Another series of imaging here, again showing areas of enlarged segmental or subsegmental pulmonary vessels without clots in them on CT. And some radiologists suggest that perhaps this abnormally enlarged vessels maybe has something to do with microthrombi that we can see here, and in situ thrombosis, but we are not really sure at the moment. And I guess further evidence that perhaps there is a pulmonary vasculopathy going on is that indeed when you look at histology, there is evidence of the endothelium being affected with inflammation in a perivascular distribution, microthrombi in the lungs, and heavy distortion of the microvasculature in the lungs. And indeed, the pulmonary endothelium, and indeed endothelium in general, can be directly infected by the coronavirus. And there is some nice pictures here from post-mortem staining in endothelial cells from a number of organs, and certainly the ACE2 receptor is found on endothelium. So these are all very high. So it's good evidence that there is effect on the pulmonary vasculature. So this is kind of the what I wanted to talk about for the acute setting from the biology and the hypoxia and the physiology perspective. And I want to move to talking about the post-COVID, the recovery period of COVID, because part of my role now is looking after patients in a post-COVID respiratory clinic, which is a new clinic that we've set up with 2 other colleagues. We're also trying to integrate that with research, and it's quite useful to have seen patients acutely in the hospital and see what happens next. And really the first thing to say is that the group of patients that we see are very heterogeneous. So we see patients that had initially severe acute pneumonia, similar to the ones we looked after in the hospital, and some of them have complete resolution of symptoms, others have persistent abnormalities on their lungs with fibrosis. Usually, from my experience, these are patients that were mechanically ventilated. And some patients have really good radiological resolution, but do have persistent exertional breathlessness and functional limitation. And although the remit of the clinic initially was to follow up on these complications of the hospitalized patients, we are seeing in our clinic referrals from the community as well. And it's quite interesting to see again the variety of symptoms, because there are patients that had very mild illness to begin with that did not require hospitalization, and yet they do experience debilitating symptoms later and that persist. And from a respiratory point of view, some patients have cough and wheeze, so they present in a post-viral type of illness. When patients have never had asthma, for example, before, palpitations, exertional tachycardia, functional limitation, and exertional breathlessness. From the respiratory side of things, there are a lot of other multi-system effects, of course, as well, as you might know, in these patients. And really thinking about, how we should look after these patients and what sort of research we should be doing to look at post-COVID effects in survivors. What should we focus on, and why should we focus on these things? And I'll just make some points in how we view this and why. So I think what is important is to try and have an unbiased approach in trying to identify distinct phenotypes in the recovery phase. This is a new illness. We've never had to deal with it before. And, I think we have to be open in terms of what might be the sequela, what we might expect. For example, fibrotic lung disease may not be what is happening. We should remember that the effects of COVID-19 are multi-system, cardiovascular, brain, hematological, infectious diseases, etc. So I think it's important to try and have a multidisciplinary and interdisciplinary approach. It's important to recognize that this is a national emergency, so having national collaboration between centers where you can share information and have large number of data is also very crucial. And what I think is also very important is as we go along, if you integrate research with clinical care, I think you can provide a much better assessment and investigation of these patients with higher yield of answers. And so we've got 2 post-COVID respiratory integrated with research clinics, and we try and have a cross-specialty MDT every week to discuss some more challenging cases. And why is important to do that? Well, of course, an obvious reason is because we can provide better treatment of patients in the recovery phase. It's important to try and relate long-term effects with what the acute illness presentation is that can give you insight into the disease. But also when you have the chance to study patients using different modalities, something that you may not be able to do in the acute phase, that gives you again potentially insights into the mechanisms of the acute disease, and that may have therapeutic implications as well. And really the aim is to, our sort of theme in respiratory medicine is to try and identify traits that are treatable. So what we do from our clinic, Oxford is part of the FOSP COVID study. So that is a national study, post-hospitalization COVID-19 study, which is led from Leicester and funded by the NIHR UKRI. In trying to understand the effects of COVID in hospitalized patients. So Oxford is a part, and we try and coordinate this study through our clinic. And essentially, there are 3 tiers. Tier 1 is trying to collect as much clinical data as possible from across the centers. But these are clinical data. Tier 2 involves recruiting a subset of participants where they come for dedicated research visits that involves enhanced testing. And tier 3 are other studies that are linked to FOSP's COVID, where patients can be recalled for further detailed sub-studies. And tier 2 visits typically happen around 3 months post-discharge and around 12 months post-discharge, and they involve a series of symptom assessments with questionnaires, quite extensive questionnaires, assessing functional limitation with lung function tests and exercise tests, and also biosampling, genetics, blood for inflammation, immunology, transcriptomic biomarkers as well. And clinic with the support of the Respiratory Trials Unit. And it's important to say that this study is linked to a sister study, the Seymour multi-organ study, which is predominantly an MRI imaging study. And there are also various other groups that we are linking in with that have their own subspecialty interest in these patients, which is quite nice to try and coordinate everything together. And what I want to briefly mention is our interest in lung physiology, and this projects that we're taking forward with Nick Talbot and other of the respiratory consultants in trying to understand in more detail the physiological effects of COVID. If anyone wants to get in touch with the coordinator, either to refer patients to the study or refer them themselves, if they've been ill, this is the email of the FOSP-C coordinator. And yeah, as I said, so our particular interest in respiratory physiology in these patients is really to try and undertake a very detailed integrative physiology phenotyping to see, is there any residual abnormal cardiopulmonary physiology in these patients, and how does that relate to their acute presentation? How does that relate to other effects, such as, for example, radiological abnormalities? So what we're looking for is persistent abnormalities in gas exchange. Is there presence of shunt? Is there VQ mismatch? And is there any, the second part is, can we identify any persistent attenuation in the hypoxic pulmonary vascular response during the recovery of these patients? So this is work in progress, and I'll just touch on a couple of the things we're doing. So we've got a new technique that measures gas exchange, which is shown here, and this is a novel gas analyzer that uses laser absorption spectroscopy. And the idea here is that it very precisely measures flows and the concentration of respiratory gases as people breathe in and out. So very accurate gas exchange data. And we typically do a multiple breath washout test where we give people to breathe air for a few minutes and then oxygen for a few minutes. And by looking very carefully, by using the very accurate gas exchange data with a mathematical model of the lung, what we come up with are indices that essentially describe different physiological properties of the lung. And really what we're looking at is trying to pick up variation in how gas exchange happens in the lung. And this variation could be in how, in the lung elasticity and how well the lung ventilates in different parts, variations in dead space across the lung volume, variation in blood flow across the lung volume. And also we can compute some ventilation perfusion relationships here. So this is part of our assessment on the patients. And the other thing that we are almost ready to start is taking some patients to the lab and studying them with hypoxia to look at their response to hypoxia from a ventilatory, cardiovascular, and pulmonary vascular response. We've got a new way of doing that in a very, very controlled manner. But these are all pictures from, we had a lot of experience in the laboratory and lots of experiments in the past when we would expose healthy volunteers and patients to hypoxia and study their heart with echo to look at their pulmonary vascular response with echocardiography. And this is a typical experiment. As I said, these are old experiments. These are not with COVID patients, where patients are exposed to 10 minutes of hypoxia down to an end tidal oxygen of about 55 millimeters of mercury while keeping the carbon dioxide constant and looking at their pulmonary pressure and how that changes. So this is, as I said, work in progress. And in addition to these novel things that we're doing, we're also doing some more regular testing with spirometry, gas transfer factor, nitric oxide, small airway function tests, exercise tests, and we're collecting blood for some cellular assays as well. I think this is all I had to say. Thank you very much. These are a lot of people that are involved in this post-COVID work across the university and the hospital and elsewhere. And if anyone wants to get in touch, that's my email address. Thank you very much.
Thank you very much, Dr. Petousi, for the wonderful lecture. And now we'll transition into the live Q&A session. Throughout the talk, we had several questions submitted, which we have been keeping an eye on. The first of which is there more new evidence that COVID-19 is airborne?
I don't know. I mean, the evidence is the same as it was before. We know that aerosolizing procedures are, risky procedures in terms of spreading the virus. So we have to take all the precautions that we need.
Yeah, thank you very much for the answer. The next question is, sorry if I missed this, but how were patients selected to be part of the study?
Which study? Which study exactly?
This was at the
So
yeah, not really sure.
So the FOSPC study, which is the national study, that is a multi-center study, the one that is from Leicester, but we take part. These are for hospitalized patients. So really any patient that has been hospitalized, even if it's briefly, are eligible to take part. So we try and, get these patients referred to us from the admitting team or the discharging team. But really, so these are the eligibility criteria for that study. For a more dedicated lung physiology study, we predominantly study the hospitalized patients, but we can also study patients that had proven COVID, but were not necessarily hospitalized.
Yep. Thank you very much. The next question we have is, do you think there's any role for proning in easing symptoms of less severe disease?
I don't know necessarily that proning helps symptoms, but it definitely helps with improving oxygenation. So I think our colleagues in the infectious diseases ward, where they patients who have who do not require respiratory support but may require a little bit of oxygen, they're also encouraging proning. So definitely, for hospitalized patients that have an oxygen requirement, it's something that we would recommend if possible, if patients were able to do that.
Great. Yeah, thank you for the answer. I think the next question we have is, thanks for the great talk. This is less of a clinical question, but how has your experience been working at the front line of the pandemic?
So my personal experience.
Yeah,
I think that's what I tried to sort of highlight at my first slide. I think initially, there's quite a lot of anxiety, this anticipatory anxiety, because it's something unknown. You've just, you try and, learn from experience across the world. You hear horrible stories in the news, and it's but I think once you get going, the first couple of weeks, steep learning curve, very, difficult cases, difficult situations that we had to deal with. But as I said, I think the more we did that and we worked as a team, and the more confidence you get in that, you now know how you treat patients. Some of the treatments are working, you see those effects, that gives you quite a lot of satisfaction. It was very difficult to see, patients being alone without their family members there. That was a very, very tough from a clinician point of view. I thought for me that was the most difficult aspect. I think that the tiredness and the fear of perhaps catching infection, that went once you got going. But I think the sadness of actually seeing patients alone in the hospital at such critical so that was very difficult.
Yeah, definitely. Thank you for the answer. I think the next question we have is there any collaboration with international organizations happening at all?
I'm not involved in any myself from the work that I've described. Yeah.
Yeah. And the next question is, you mentioned long COVID-19. Is this persistence of the respiratory symptoms, or is this more linked to the systemic effects on other organ systems?
Yeah, I think that's a very good question, and as I said, we're beginning to see patients in our clinic, and I think the groups of patients are very heterogeneous, and yes, there are a lot of effects, such as fatigue, even patients presenting with ongoing fevers, muscle weakness, brain fog. So it's really multi-system, and there are the respiratory symptoms as well. And sometimes patients present with a multitude of symptoms. Sometimes patients may have more isolated respiratory symptoms. I mean, our expertise is on the respiratory side, but I think we recognize that unless you have a multidisciplinary approach where you can sort of share knowledge and signpost patients between services, is quite hard to to provide effective management. So this is something that we're pursuing.
I think we have the final question today. So the question is, what was the outcome for those who were immune compromised and caught COVID?
Yeah, I mean, we had patients on the ward that were immunocompromised with hematological malignancies that had chemotherapy, or transplant patients, and we saw a mixture of outcomes. Some people did well and survived, and some people had more severe disease and required intensive care.
Sorry. Yeah. Great. I think that covers the last question by the audience. Thank you very much, Dr. Nayia Petousi, for taking the time to present your research today and to answer the questions for us today. We really appreciate it. Before we finish, thank you. Before we finish, I'd like to thank our sponsors, the Oxford Centre for Personalised Medicine, the Wellcome Centre for Human Genetics, and St. Anne's College once again for their support, as well as our audience members for their attention. Please make sure to register for our OUPM membership if you haven't, to get involved in our upcoming exciting events, which will be announced soon. And just a reminder to register for CPM's lecture on host microbiome interactions in health and disease by Professor Iran Ilinaev, which will be taking place tomorrow, 5 p.m. Thank you, and we hope to see you soon. Thank you so much, Dr. Petousi.
Thank you. Good night.
Good night.